Okay, it's recording.
All right. We're going to start early tonight on cardiology, in chapter 31. There's a lot to cover, and I feel like if I don't get started, we won't get finished on time. So if you're joining us a little bit later, that's all right, because it will be recorded. So what's the leading cause of morbidity and mortality within the first year of life? Well, it would be children with congenital malformations. Congenital heart disease, CHD, is the number one cause of morbidity and mortality in that first year of life. So February is Heart Month, so the 7th through the 14th is Congenital Heart Defect Awareness Week, also known as CHDS. The most common birth defect in affecting 1 out of 100 babies, so that's pretty frequent. Some require surgery, and there are 35 different kinds. We're not going to go over all of those, of course, today, but just to let you know, there's many different types, and some show no outward symptoms. Most have no cause, and 40,000 babies each year are born with heart problems. In case you have forgotten about fetal circulation, there is a YouTube you can watch, a short YouTube, to help you refamiliarize yourself with fetal circulation. There's also one I found pretty good for normal postnatal circulation as well. So what are the risk factors for congenital heart disease? There are many risk factors. Perinatally, there's CMV, cytomegalovirus, rubella, and viral syndromes, especially things like the flu. The mother uses tobacco, alcohol, street drugs, ricinic acid, hydone, lithium, valproate, ibuprofen, ACE inhibitors, naproxen, tricyclic antidepressants, sulfonamides, and sulfasalazine. Also, maternal chronic illnesses like lupus and diabetes and phenylketonuria, congestive heart disease, congenital heart disease themselves, because there is some genetic component to that. If they're over 40 years of age, and if they had excessive weight gain in their pregnancy or they're diabetic. Risk factors for congenital heart disease in the neonatal period are if they've aspirated, them without oxygen, they were born premature, had some kind of genetic chromosomal abnormality, and there's several that have heart problems connected with them. If they've had a strep infection, or their birth weight was below 2,500 grams or less than 2 standard deviations from the mean. So in the newborn period, if they're born with a murmur or high blood pressure, or they're having trouble eating or short of breath, they get tired easily, so they don't suck for very long. They're diaphoretic, poor intake, cyanotic when they cry or eat or exert themselves. And then if they have increased breathing, then those are all signs of risk factors for heart problems. In the toddler, school age, and teenage years, the risk factors are, again, if they've deviated from normal growth and development, or they're unable to keep up with their peers on play, like running, riding a bicycle, playing ball in the backyard. If they have frequent respiratory infections like pneumonia that last longer than normal respiratory infections, prior murmurs, flu spells, strep infections, high blood pressure on 3 separate occasions, chest pain on exertion, shortness of breath with exertion, fainting or dizziness with the heart rate change, tachycardia or bradycardia, or fluttering in the chest and racing in the heart. Those are all risk factors. In the family, if anybody in their families had congenital heart disease or sudden death, or a myocardial infarction before age 50. And this would include deaths by drowning as well, because you could have a heart problem if you're swimming and die. Hypertension, rheumatic fever causes some heart problems. There's genetic syndromes. And then, of course, if you've got triglycerides and cholesterol problems in your family. Physical exam-wise, when you're assessing the heart, you should include the rate and the rhythm, and it should always be auscultated. You should always listen with the stethoscope. Increased heart rates are caused by excitement, anxiety, hyperthyroidism, heart disease, anemia, or fever. Most people don't realize it, but for every degree of elevation of heart rate, every degree of fever, your heart rate increases by 8 beats. Irregularity may be caused by sinus arrhythmia, which is normal. So if you see an increase in heart rate upon inspiration and a decrease upon expiration, that's normal sinus arrhythmia, and it usually lasts up to 16 years of age, and it can last longer. So here's a great site to let you hear all kinds of heart sounds. I think there's some in your course as well. Really good to listen to those so that you get used to it. Hi, Rhonda. For pulses, you need to palpate in the lower and upper extremities for strength and variation between these different sites. Bounding pulse, you might see with what's called patent ductus arteriosus or aortic insufficiency. A weak or thready pulse, congestive heart failure or aortic stenosis, and then strong brachial pulses, but weak femoral ones, coarctation of the aorta. So again, if you're used to knowing what goes with what, you can begin your diagnostic right then and there as you do your physical exam. Blood pressure is measured at age 3 and up. Again, auscultation is the preferred way, not by machine, because machines can vary. And anything above the 90th percentile concerning. For arm pressure, the width should be 2/3 the length of the upper arm, measures from the axilla to the antecubital space. Initial evaluation should compare the pressure in all 4 extremities, and they should all be equal, with leg pressure being a little slightly higher in a child that's walking. It's just gravitational pull on the body is what you're seeing there. The respiratory rate, you should evaluate the rate, the effort, and breath sounds in all 5 lobes of the lungs. And anything over 40 in a young child or 60 in an infant is worrisome and needs further evaluation. An infant with a congestive heart disease may be tachycardic and not show signs of grunting, intercostal retractions, nasal flaring, or tracheal tuck. It's an essential vital sign in cardiac assessment is the level of oxygenation. There are some genetic syndromes that you see having congenital heart defects. In the left upper is Down syndrome. In the middle upper is Marfan, which Abraham Lincoln had, where you're unusually tall with the arm span wider than the head toe height. Upper right is microcephaly. Lower right is Turner's with the webbed neck and prominent ears. And lower left is the face of a child with fetal alcohol syndrome. So all of those could have congenital heart defects. So when you're looking to examine a child with possible heart problems, the skin and nails, you would look for modeling or central cyanosis at rest. There's a little kid with blue secretives. Pale red or pale blue or ruddy red color of the mucous membranes. The tongue is really a great indicator for cyanosis because there's not much going on there. peripheral cyanosis or acrocyanosis, blueness or pallor around the mouth and hands and feet when an infant's cold, which wouldn't be related to heart, and clubbing of the fingers, which you see in that picture, may be seen in long-standing cyanosis. Respiratory signs, you're going to be looking for wheezing, nasal flaring, retractions, prominent neck veins, and head bobbing. And that video that I have a link to there is excellent. It's with explanations given to help you understand the diagnosis of respiratory problems that can be assisting you to know your signs and symptoms and what they indicate. It's a really good video. Edema is something else you might see. Here's a little kid with periorbital edema, which may be present in a child with congestive heart failure, even if peripheral edema is not there. True pitting is really unusual to see in an infant. Besides peeing, pooping, eating, and sleeping, those were the 4 criteria, remember. What is the most important thing to watch for in a child to determine if they're doing okay? Well, again, it's the growth and development. It's extremely important to follow. And we haven't talked a lot about that, so I want to take a minute and discuss that. Height and weight on a growth chart, what you're wanting is a normal rate of growth, which means that the child's growth points closely follow a percentile line on the chart. So you want to see the height and the weight kind of go up steadily on the same percentile, traveling right along. And we usually don't worry about insufficient or excessive growth until it's crossed at least 2 of those percentile lines, or from above the 90th percentile, where it should be, or to below the 50th percentile. So it should, if you're going from 2 lines, 2 percentile lines, you're crossing those, then that's a problem. If a child's weight, height, or head size is below the 5th percentile, that's a problem, unless the family is unusually small. The daddy and the mother are petite, then the baby's not going to be large, and they may all have traveled on the 5% or less growth chart line. So you want to see them parallel and not anything falling behind, which would be more concerned. If you're worried about the child's too skinny or they're overweight, then you need to look at their BMI. See so whether the weight is close to what it should be given their height. So palpitation on the physical exam, you need to palpate the 5 areas of the chest. And you do that with the open palm of the hand near the base of the fingers. So you would palpate the aortic, pulmonic, tricuspid, and mitral areas. You assess for pulsations, lift, heaves, or thrills to determine the location of the apical impulse. And that is the most lateral point at which cardiac activity can be palpated. It determines the size of the heart. So if the heart is enlarged, it will shift downward and laterally. It should be at the 4th base in infants and children and the 5th in children 7 years and older. So to assess the pulse, you can watch the video, which kind of helps you with that. Assess for thrills, which are palpable vibrations caused by turbulent blood flow. Septal defects will have thrills, so atrial septal or ventricular septal defects will have thrills. Assess the peripheral pulses for how strong they are. Assess the liver and spleen for enlargement. In infants, you might be able to feel the liver edge in them. If you want to remember how you examine the liver, then this will kind of help you, this YouTube short video. And back should be assessed for scoliosis, because scoliosis can cause, as the body curves, it can cause the heart to be impinged upon as well as the lungs. And when you're listening to the heart sounds, S1 is the closure of the AV valve, and you can hear it at the apex. And if you're interested to know if that's what you've got, then it's synchronous with the apical and carotid pulses. So as you're listening to the heart, you can feel for the apical pulses. The S2 is best heard in the upper left sternal area and the pulmonic area. And then S3 and S4 are pathologic, and hopefully you won't hear that. But that little link there will help you with these heart sounds pretty good. For murmurs, I've given you another link that goes into a lot of the things that your book talks about, but a doctor's discussing them for you. What it doesn't go into the video is the grading of murmurs. So it would be very unusual for you to hear some of these louder grades, like grade 6, where you hear it without a stethoscope. I can't imagine. I imagine there would be a time in outpatient when you could hear that, but it would be very rare. Grade 1, a lot of people probably miss, and that's why I use that stethoscope that's electronic, that amplifies sound so that I can hear grade 1s and not miss them. Grade 2s are soft, but you should be able to hear them. And then 3 is moderately loud, so it's not something you would miss. And 4 and 5 and 6 would be probably not missable heart sounds. They're so loud, and you just barely have to put the stethoscope on the chest. And like I said, the link helps you to actually hear. It's a great link to listen to all of the murmurs. Murmurs are normally just a swoosh that shouldn't be there. So as you're listening to this link, you should be able to hear a lot of those. And this one too, I've given you a couple of links to listen to murmurs. If you're not used to hearing them, then you always can use practice. What kind of diagnostic studies might you be ordering? One is a chest x-ray, because it really tells you a lot about the heart size, the chambers and vessels, the blood flow. Electrocardiogram, if you're suspecting that they've got arrhythmias, it will help you to know about the electrical activity of the heart, whether there's a ventricle that's hypertrophied. Echocardiogram, you probably won't be doing. A lot of cardiologists have those in their office, so if you're referring a patient, you probably don't need to do an echocardiogram. It'll be an enormous charge to the patient if you order it. It's best to send them to the cardiologist for that. Complete blood count. Anemia will cause tachycardia. Polycythemia, just a lot of red blood cells in there, so the potential for thrombus is always there with these patients. And then a cardiac catheterization goes right into the heart and is able to determine things like cardiac output. Hypoxia test, if you're supplying 100% oxygen, then resulting in pinking only if the problem is respiratory. If it's heart, you won't get much change in color. An MRI shows heart structures, chamber volumes, and chamber functions. Again, not likely that you would be ordering that. You need to be able to differentiate an innocent murmur from a pathological murmur. That is on page 765. For your exam, you will undoubtedly get a case study in which you'll have to try to figure out if it's an innocent murmur or a pathological one. So pay attention to that page. General management instructions of children that have cardiovascular problems are to make sure that they get the intake that they need. And a lot of these babies have poor sucking because they're so worn out that they don't have enough oxygen to their bodies. So you may have to give them extra formula, extra calories in their formulas so that they, when they do suck, then they're getting the calories that they need. The thing with children is that with any child that's got a chronic condition, there's a tendency to baby them and not treat them very normal. And so they end up with, behavioral problems and psychological problems. And they know they've got a chronic disease. And so it's really important to try to give them a quality life and as normal a life as possible. They need their vaccines. You may have to, if they had a cardiopulmonary bypass, you may need to delay their MMR and varicella for 6 months afterwards. All the others need to be given at time. And this is probably the child that needs that respirosyncytial virus prophylaxis, especially if they're younger than 1 year of age. That shot is given, remember.
Yeah, the second one's going on now.
People older than 19 years of age,
yeah, there was on the first one
if they're spending time with them, they need to have their Tdap, even if they've had their TD. Prevention of avoidable complications, good hand washing, and avoid people with upper respiratory infections and vaccinate them against the flu. They can have their flu shots. If they're going to go to the dentist, many of these patients will need prophylactic antibiotics. And it's important that they go to the dentist because your mouth, remember, is not very sterile. And it's a great haven for a lot of bacteria that can work their way into the bloodstream, into the heart. They do need, as best they can, daily physical activity. So but you still have to make sure that they're not going to have chest pain or they have a lot of dyspnea or dizziness or pass out. Normally, these children will squat down, which will push all of the blood up to the heart where it's needed in the brain and cut it off from the circulation. They will self-limit their activities, a lot of these children. So you need to assess for problems that they might have due to lack of oxygen to their brain with some tasks that involve space or fine motor function, language skills, memory, and or attention. So you need to see how they're doing, walk hand in hand with their teachers. So one important thing is to know who goes to the cardiologist. Well, if their oxygen saturation in room air is less than 95%, or if they're having those symptoms of congestive heart failure, or a very loud pathological murmur, if they're not growing, or if they have a lot of cardiovascular states, they're having any kind of murmur, then they need to be evaluated initially by a cardiologist. Infants with a change in breathing patterns, poor feeding, cyanosis, irritability, dizziness or pain, arrhythmias, those are the people that need to be evaluated at least once by a cardiologist. So what are the etiologies? What causes all these problems? The heart develops between the 2nd and 8th week of gestation. So during that period of time, if the mother's exposed to organic solvents, pesticides, air pollution, or any of the drugs or agents that you see listed there, then there's a chance that the heart development will be interfered with. Diabetes, we know that diabetic moms, if you're an OB, you know that that is a caution. any kind of febrile illness, especially flu between the second and 8th week. And then it's also multifactorial. There are a lot of things that go into play when you're looking at the heart patient. So let's take case 1. Jonathan is a 2-week-old infant born prematurely and placed in the neonatal nursery. He has been diagnosed with a large ventricular septal defect, but has been discharged home to be followed up by his primary care provider, you, within a couple of days. The mother calls you and says that while they are supposed to come tomorrow, she says she is worried about Jonathan because he acts like he is having trouble breathing. She hears sounds in his chest and he's not breathing because he acts like he tires out easily. Around his eyes look swollen and he is sweating. What do you think is going on, and what are you going to tell her to do? What do you think's happening to Jonathan? Think he might be having congestive heart failure? He has some of the symptoms. So what are you going to tell her that he needs to do? Where are you going to send her with him?
The hospital.
Absolutely. So case 2. Tabitha is a 3-year-old that went to the clinic and you diagnosed a systolic murmur grade 2 on her that was heard best at the pulmonic area. After a trip to the cardiologist, she was diagnosed with an atrial septal defect. She has a acyanotic or cyanotic, one of the other, heart defect because the blood flows from left to right due to the higher pressure on the left side of the heart. Knowing this, would you expect her to be cyanotic? What does she have, cyanotic or acyanotic? What do we know about the blood that's on the left side of the heart? Is it oxygenated or unoxygenated? Where is it going? It's going out to your head and the rest of your body, isn't it? And if it's on the left side of the heart and it's going out to your body, then it's got to be what? Are you in trouble? It's got to be oxygenated, right? So she has an acyanotic heart defect because what she's got is blood flowing from the oxygenated side of the heart to the unoxygenated. So what would you expect her symptoms to be and why? She would have dyspnea and fatigue easily and probably have a history of frequent respiratory infections. Because you're putting more fluid in the right side of the heart, and where is the right side of the heart going? The blood there is going into the lungs. So if you have extra fluid going into the lungs, something that's never good, right? Then you have all that fluid in there, there's a chance that that fluid, like a stagnant pond, will grow something. And she'll have respiratory infections and be short of breath because her heart is flooding the lungs with fluid that's normally not there. What will she have a history of? It is not treated in the short term. Well, of course, she'll have frequent respiratory infections. And what about the long term? Okay, if you're looking at the heart and the right side of the heart is getting extra work, then you could have anything from right-sided heart failure because that side of the heart will wear out. Or you could have more pressure in the right side, which you have, and reversal of the shunt. And so instead of left to right, it'll become right to left, and you've actually worn your heart out. Case 3. Timothy he has a large ventricular defect and has early signs of congestive heart failure. What medications might be ordered for him, and what should you know about Lanoxin? Well, the site that you're seeing there gives you a lot of information about how to give Lanoxin to children. But Lanoxin is just one drug. Certainly, diuretics, ACE inhibitors, and beta blockers would also be some choices with these children. Case 4. Jerome is a one-day-old male who was large for gestational age, weighing in at 10 pounds. It was immediately evident at birth that his cyanosis was not going away. He had transposition of the great arteries. His aorta arose in the right ventricle, which should have been the left, and his pulmonary artery arose from the left, which should have been the right. His aorta receives deoxygenated systemic venous blood and returns it to the systemic artery. His pulmonary artery receives oxygenated blood from the pulmonary venous blood and returns it to the pulmonary circuit. What needs to be present for these children to live? Well, certainly something needs to be, because if it's not, they will die. So communication between the right and left atrium or ventricles or patent arteriosus needs to be present, so there'll be an exchange of the blood. And sometimes prostaglandin is given to delay closure or to reopen a patent ductus arteriosus. It's a very serious condition, but children do survive it, and they have surgery for it. Enrique is a 6-month-old infant with tetralogy of flow. He has all 4 anatomical cardiac defects: pulmonary valve stenosis, right ventricular hypertrophy because the blood can't go through the pulmonary valve, ventricular septum, that sometimes the aorta also overrides the ventricular septum. He has dyspnea and cyanosis and a harsh systolic murmur. He has a history of poor weight gain. How will you handle his hypercyanotic episodes? So remember when I told you that children compensate on their own by squatting? Well, so you have to reinvent that in this child. You have to place him in a knee-chest position, soothe him so that he doesn't get upset and hyperventilate, and give him oxygen, decreasing that right to left shunting and increasing the pulmonary blood flow. So you have to do the squatting position for this little 6-month-old. Case 6. Jessica has pulmonary stenosis and Tricia has aortic stenosis. How will you know from the symptoms who has what? Well, with aortic stenosis, you'll see normal growth and development. They will have some intolerance of activity, chest pain, fatigue, syncope, a narrow pulse pressure, and harsh systolic murmur. With pulmonic stenosis, you would think about where that's going. You'd have exertional dyspnea, fatigue, and cyanosis. But both children can participate in all sports. And eventually, like most conditions, depending on how severe they are going to need to be fixed, or the heart is a muscle and will wear out without being fixed. Esmeralda has Turner syndrome and has been diagnosed with coarctation of the aorta. She is 6 weeks old and has had her aorta dilated. She seems to be doing well post-operatively. What would have told the practitioner that there was a problem? Well, to begin with, the discrepancy between the upper and lower blood pressures. Lower body could have had mottling or absent pulses if you were trying to find them. What should you watch for in these children long term? Well, you should watch for things like signs of congestive heart failure, which would be a gallop rhythm, poor feeding, and possibly cool lower extremities, bounding pulses, and there is a possibility for rearcation. So you can have that same situation that you had before with the difference in the blood pressure. They may participate in sports if there's less than 20 milligrams distance between the upper and the lower, but they should avoid things like weightlifting and wrestling up to 1 year after the surgery. But remember that they can go back, excuse me, to coarctation. Now, what are the long-term complications for these children? There's left-sided lesions. So for the left-sided lesions, you need to watch for arrhythmia, sudden death, endocarditis, syncope, and angina. For the left to right, again, there are arrhythmias, dyspnea, and then you can have some unexplained deterioration of function, which would, again, be congestive heart failure. Chronic cyanosis, where the body's trying to compensate for that by making red blood cells, and valvular problems like mitral valve problems and risk of arrhythmias and sudden death are some of the long-term complications with these children. Ventricular failure, where the ventricles wear out, and then arrhythmias and heart blocks, where palpitation and chest pain is a problem. Sudden cardiac death. I guess that's what a lot of people worry about when they do the sports physical. And I did post a question for you on your discussion board. I know it's not for some of you a required activity, but it might be worth debating because it has been debated for years among people doing sports physicals, and the viewpoint from Europe and the United States is totally different. Most common cause of sudden cardiac death is hypertrophy of the muscle of the heart or arrhythmias in the right ventricle. Both are inherited in structural abnormalities of the muscle of the heart. Other common problems that you find causing sudden cardiac death is coronary artery anomalies, aortic rupture, mitral valve prolapse, and aortic stenosis. I can tell you a little bit about Wolff-Parkinson-White syndrome. If you haven't heard of WPWS, I can tell you about it because I have it and lived with it for years. I didn't identify what the symptoms were till I was about 30-something years old, and I decided for my health that I would go to a health club, and one of the requirements at the health club was that you had to have an EKG done before you could play there. So I had that done, and the woman looked at me and she said, "You've had a heart attack." So, well, that's great, but I don't remember that if I did. So I went to the cardiologist and I described my symptoms, which were I would, feel my heart race, and then I would kind of get dizzy, and then it was like my tongue was going toward the back of my throat, much like if you were expecting that you would feel if you were having a seizure. And what I would learn to do was to cough or hold my breath, which is basically the Valsalva's maneuver. And I would often tell people that I worked with, if you catch me lying in the floor, I'm really okay. I'm just trying to convert my heart back into normal rhythm. So I did have a cardiac catheterization with an ablation in Wichita, Kansas back in the 80s, I think, when they were first doing them, because I don't think they knew a lot about what they were doing. And they told me, well, tough rocks, we can only fix 50% of your problem. So I never remembered if it was up, down, or down, up. problem that they had fixed. So I began to have more problems. So I went to a cardiologist at Wellmont, and he said, well, you can have another cardiac cath. And I said, no, thank you. I said, what I'm here for is to know if I've got the up-down or the down-up problem, and if it's the kind of problem that you have sudden cardiac death from. That's all I want to know. So he checked me out, and he said, well, you're not going to die from it, but it's a big aggravation for you. I said, well, that's all I wanted to know. I'm not having a cardiac cath. If it's not going to cause a sudden cardiac death, I'm out of here. I'm fine. I can compensate doing the Valsalva maneuver. So I can tell you a little bit about that. Some people have the long QT syndrome. That's where when you scare them, all of a sudden they can actually die of fright. I guess that's where that saying came from. But with Parkinson-White syndrome, you're actually born with two electrical systems in your heart, and so occasionally it will jump off on the other system, which can make your heart go up to 200 beats a minute. And they have said that as you get older and your original electrical system wears out, then it's going to be jumping onto the other one more commonly. So I'm waiting for that to happen. That really has not happened to me yet. But it's scary, but, you know, since I know I've either got the up-down or the down-up problem, I'm not really worried that I'm going to die from that. Something else probably. So if you have a blow to your chest, somebody decides to do CPR on you and you don't really need it, then that can cause sudden cardiac death, myocarditis, performance-enhancing drugs. Cocaine is famous for causing heart problems. So if you already have a heart problem, the last thing you need to do is use cocaine or any of the other drugs. Then you can, of course, have premature coronary artery disease, and there is a condition called progeria where you age quickly in your youth. So you need to watch for signs of shortness of breath, palpitations, dizziness, lightheadedness, chest pain, with or without activity. Those would be all concerns, and you would need to send your patient to the cardiologist for those. So who do you refer? A family history of sudden cardiac death would be a clue. Inheritable cardiomyopathies, Marfan's, because the aorta actually can dissect, because these people are so tall that the aorta has stretched, and it can stretch only so much before it breaks apart, and they have sudden death. Chest pain is of a concern, as well as syncope. Or if you had Kawasaki's disease, you can have cardiac disease as a result of that. Or if they already know you've got a congenital heart defect. Cardiac rhythm disturbances, like Parkinson-White or long QT, and then palpitations are concerning. Any child who has chest pain that worsens with exercise, or that suggests angina, or if you find positive findings on their exam, then you need to do an EKG or chest x-ray and check into their family history. The first goal of chest pain evaluation is to rule out that it's due to something in the heart. In page 782 of your book lists possible causes of chest pain for you to review. The most frequent cause is musculoskeletal. You can also have chest pain if you've been in peds long enough. You're going to hear a little kid come in and complain of chest pain upon exercise. And if they have a history of allergies and asthma in the family, a lot of times the way that you diagnose asthma, or begin to think about diagnosing asthma, is chest pain upon exertion, cough at night. But chronic chest pain can also be due to anxiety or hyperventilation. People that have panic episodes have chest pain. But anything that is connected to syncope, exertional dyspnea, or irregularities in the heart rhythm, you definitely need to send to the cardiologist. History taking with chest pain. So you want to know, is there pain related to exercise or exertion? And if it is, then you want to do a pulmonary function test. Is there any syncope, dyspnea, or wheezing? Burning substernal pain is more like a GERD that worsens when you lie down or you eat spicy foods. Pain that is sharp or stabbing and lasts for several seconds to minutes, located over the mid-sternum or infranipple area and occurring with non-exertion and deep inspirations is worrisome. Pain that awakens the patient is scary. Congestive heart failure signs and symptoms, you can do an EKG and it will help you determine that, or a chest x-ray. If they have a rhythm disturbance, you can do a 24-hour Holter monitoring or a 30-day monitoring. They tried that on me, but I'm allergic to tape and latex, so that didn't work very well. I was able to keep it on for about 3 days, and it had to come off. Any associated symptoms such as fever, nausea, vomiting, headache, choking episodes, then you might need a chest x-ray. And medication, drugs, tobacco, or oral contraceptives can cause or concerns with chest pain. You can have an MI, of course, to be on oral contraceptives. Hypertension is something that you might see in children. Normal is below the 90th percentile, and there are hypertensive charts. I think you've got one in your book. And with children, it's related to the age, sex, and height. Blood pressure in the 95th or higher on 3 separate occasions is hypertension. And even adolescents with blood pressure of 120 over 80 are considered hypertensive. So there's stage 1 between the 95th and 99th, stage 2 greater than the 99th. Most hypertension that we see these days is related to sedentary lifestyle, obesity, and stress. So that is the place to start to prevent hypertension for sure. That's primary hypertension, but secondary is often due to kidney disease or the coarctation that we talked about, or endocrine disease like hyperthyroidism, genetic disorders, drugs. It's always nowadays something to be concerned about with children. Central nervous system tumors, which are probably rare, and neurofibromatosis and tuberculosis, sclerosis are typical children with hypertension. So when you're taking the history, you need to ask them about the pregnancy and delivery and the newborn period. Were there any problems? Ask them of a child if they've ever been in the hospital or had trauma. A lot of problems now that children have, we know, are trauma-based problems. I don't mean physical trauma, I mean emotional trauma. Discuss the dietary habits, physical activity, their sleep. If they're not sleeping, their blood pressure is going to be up. What kind of medicine are they on? Do they smoke? Remember that drugs start in the middle school year. If they're in middle school, that's time to ask about that. Any chronic illnesses like renal disease, diabetes, seizures, urinary tract infections could cause hypertension. Do they have headache, chest pain, dyspnea, muscle weakness, palpitations, abdominal pain, facial palsy, decreased vision, excessive sweating? It should be not swearing. Family history of first-degree relatives with MI, stroke, hypertension, diabetes, hyperlipidemia, if they had sudden cardiac death, polycystic kidney disease, neurofibromatosis, pheochromocytoma, or obesity. Those are all things to ask about. On the physical exam, you want to see if they're overweight, if they've been growing, do they have signs of metabolic syndrome, are their features dysmorphic, or what are normal features? Well, you should, for eyes, for example, there are standards of normal. For the eyes, you should be able to take the width of one eye and put it between, it should fit between your two eyes. If there's more distance there, then that's hypertelorism, and you can have then, of course, a shorter distance, and they not fit but overlap. Your ears should be at the level of the corner of your eye. For the little part above your lips, there should be a little dip in there in your face, a little dip right above your lips. So there are standards for features, and most people are not symmetrical. That is, if you took half of their head and you tried to match it the same on the other side, you would see that you have, for most people, two separate individuals that look totally different. That's what makes us so interesting, is that we're asymmetrical. I don't know what it would be if we all looked like we should, matched up on each side, but anyway. You might want to look for edema and pallor and flushing, skin lesions that are common for those conditions that we talked about. Upper and lower extremity pulses, you need to check. In the eyes, you need to check. The thyroid would be certainly something to check for cardiac. Any kind of bruise, like on the aorta or the neck, you need to check. Elevated blood pressure on 3 separate occasions would be concerning. So we talked about when you might see heart problems. This is a lupus rash. Of course, it's on an older person, but you could certainly see it on a younger person. I just couldn't find a picture of it where we could actually see it. This is the tuberous sclerosis that we talked about. I did have a little patient that had this tuberous sclerosis, and their face was just covered in these kinds of things. And then this is neurofibromatosis, which would, initially on a child they wouldn't have these many lesions. But when you see these things, realize that hypertension goes along with these. So you'd certainly want to, be aware of their blood pressure. So what kind of studies would you do? You might do a complete blood count, see if they were anemic, erythrocyte segmentation rate to see if they had some kind of infection going on, the same with C-reactive protein. You might do a urinalysis and culture, and one of your classmates was talking about a patient he saw that came into the clinic, and the only thing that they could find on the child was fever. And so the preceptor checked their urine, and sure enough, they had nitrites in their urine. They had a urinary tract infection that was causing the fever. So it brought to forefront that when there's a fever of unknown origin, we used to call it FUO, then you need to check the urine. That's one of the first places to go. But to get the electrolytes, see what their sodium and everything is, blood urea nitrogen, see if their kidneys are disposing of waste like they should. The same with creatinine, plasma, renin levels to see if that's what's causing their hypertension. Now, renal nuclear medicine scans, I really doubt you're going to be doing that, but I don't doubt that you might want to do a renal ultrasound on a child. And then you can do some additional, or get somebody to echocardiogram. So this is a test that probably if the child is in stage 2 hypertension, you would want to do, and if they're younger than 10. or if you suspect there's a renal problem, then you would want to refer them. It's always good to refer if you think you're over your head and what you really want to take care of. So to manage hypertension, the salt needs to go. All of the things that would raise your blood pressure that we all take, like caffeine, smoking raises blood pressure, alcohol, and illicit drugs for sure raise blood pressure. So increase aerobic activity to 30 to 60 minutes a day, because remember, most of the problems with hypertension are related to our lifestyle, our sedentary lifestyle. Children with confirmed blood pressure greater than 99% get immediate referral to the cardiologist, and the goal is to be below the 95th. If they've got something else going on, then below the 90th may be the place you want them to be instead of the 95th. And then the medicines are the same as for the adults, but you give them in a lower dose. So on children, remember to go slow and low, always. You can always increase it, the frequency and the dose, but if you've given too much, you cannot take that away. And then just plain old stress management is good. So good old Charlie needs a valvular replacement, but he has just been diagnosed with congestive heart failure. It has to be treated before he can even think about going to surgery for his valve replacement. Upon examination, it was determined that he had gingivitis, so an appointment with the dentist was made for the next day. However, that night he developed a high fever, night sweats, headache, decreased appetite, and myalgia. You suspect what condition? Okay, so what you would worry about is infective endocarditis. So what they say is to get 3 sets of blood cultures over 24 hours, but I don't know if you wouldn't be wanting to treat somehow him, but that's what they recommend. And then if you get 3 cultures of the same organism, then you would treat it with whatever the organism is responsive to, and to do an echocardiogram, because this is the main modality for diagnosing infection of the heart. And this child would have to go to the hospital, and a pediatric cardiologist take care of him, because it can cause emboli to form. And I could not find a picture. I wanted to find a picture of what's called Janeway lesions, which are flat, non-tender lesions on the palms and soles. Then there's ossular nodes, which are small raised lesions on the pads of fingers and toes. And Roth spots, which are retinal hemorrhages with a central white spot on the eye. I couldn't find a really good picture of any of those. I really wanted to for you so you would see it. But if there's myocarditis, if it's not endocarditis and it's of the muscle, then you would hear a muffled heart sounds and murmurs and weak pulses, and even the liver enlarged with that condition. So you need to be able to differentiate myocarditis from pericarditis from endocarditis. Endocarditis, signs and symptoms on your test. Okay, pericarditis, you refer this patient to the cardiologist. These patients have chest pain, oftentimes altered by respirations and coughing. So when they cough inspired, and they may have chest pain. They have loss of appetite and lethargy, fever and irritability, tachycardia. Most of them have had some kind of viral illness in the last 2 weeks before they started with this. They have distended neck veins, and if you have the child lean forward, then they have it causes the heart to go forward. and you can better hear the muffled heart sounds. And they will have what's called pulsus paradoxus, which is a decrease in blood pressure greater than 10 upon inspiration when you're laying down in hepatomegaly. So those are the symptoms. For them, most of the treatment is inpatient due to possible cardiac tamponade. The heart, the fluid around the lungs will have to be taken off. If it's not, it compresses the heart like you just had it between your hands and squeezing it. So here are some great links for cardiac arrhythmias that you probably are already familiar with. I mean, it gives you, both of those sites are great to give you almost everything you'd ever want to know about cardiac arrhythmias. So just a fantastic resource there for you. This is another one. If you've ever heard of POTS syndrome, it's where you have orthostatic hypotension, that your blood pressure drops when you're standing. And you get a transient loss of consciousness. You can, because the blood flow to your head is diminished. Recovery is usually prompt. Just to know that syncope due to cardiac cause comes without prodromal symptoms, or it may be associated with palpitations or chest pain. So what tests would you use to differentiate cardiac from neural? You could do an echocardiogram, certainly an EKG or a treadmill exercise. You wouldn't probably be doing that, but the cardiologist probably would be, or you might send them for that. Okay, I think that's the end of the slides. I had to start a little bit earlier today for a couple of reasons. I've got to be online at 8 o'clock with something else, and there was a lot in the cardiovascular chapter. So your first exam will be on the 27th. It will be very similar to your first exam, so you can expect very similar questions, and I will give you a study guide. This is the 16th, so the 27th. So sometime probably, if I can get my act together toward the end of the week, I will supply you with a study guide for your test and let you know what the test will be over. Of course, it'll be over whatever we ended up with and where we go with the lectures before the test. But it will be multiple choice. It'll be another 2-question exam. It shouldn't be as scary as the first one because you've already taken it. A similar one to begin with. And there probably will be little cases in there for you to analyze. And what else can I tell you? And as always, I will analyze the test because I'm making up the majority of the questions, so I'm not perfect, and neither are my questions. I'm very well aware of that. I think they're fair and they're on topic, but sometimes there's room for improvement in them. But anyway, so I will be analyzing the second test, just pretty much like I did the first, and see what I find out. Actually, the computer does that for me, so it's not too difficult. So do y'all have any questions for me tonight? Y'all are doing fine in the course. I hear good things about your clinical too. I know somebody brought up the fact that there was little inconsistency from instructor to instructor about how many children you have to put in to Project Concert. So I'm going to be talking with the person in charge of the program overall and see where the inconsistencies are and see if I can help to kind of remedy those for you, because you have enough stress without having to adjust what you're doing from one teacher to the next. So I'll be working on that. So if you want to share any of those inconsistencies via email with me, I'll be happy to relay the message. I won't relay your name, but I will relay the message of what's inconsistent or giving you difficulty. Because we need to be all on the same page, you and us, so when you're doing stuff. Any questions, you guys, for the good of the order? I can't believe you're with me at fall break. I really didn't think that I would have one of you with me. I hope you're enjoying your break despite the fact that you're with me. You thought one more day of freedom, maybe, at least from school. I know how that goes. You never are, aren't you? This is the time you use to get caught up. I know how it is. The student never has a break, especially if they're working. Work goes on, whether the school does or not, and if you don't have school, it's time to take a deep breath and hit the books to kind of get caught up from when work didn't allow you to. I certainly know how that is. But anything for the good of the order tonight, you guys? Anything you need to ask me or anything I can help you with? Okay.